So welcome everybody to today's Grand Rounds, and this is the next in our series of talks that we call Badger Bytes. And for those of you who haven't had the introduction into that, this was created maybe a couple of years ago now in order to bring down silos in the world of research in the department, and because we had folks working on different areas that really could be working together and weren't necessarily knowing what each other were doing. And in fact, there were a lack of knowledge in terms of what research was going on in different parts of the department in general. And so came up with the idea that by having small, short talks about different topics, we'd be able to stimulate discussion and, most importantly, stimulate collaboration between different areas of the department and with folks that aren't even necessarily in our department. So it's been very successful. We've had topics that have been very diverse up to this point. And our topic today is on sexual health. And next slide. We've broken the talk down into two parts. The first half is about different general sexual health research and updates. I'm going to do some of the introduction just to who people are now so that we don't have to interrupt between, because we have a total of 6 speakers, 3 for each part. So we're going to be kind of moving quickly through different short talks, which again is kind of the point of this. We also didn't want to get too deep into the research because those of us that aren't doing as much research may not be able to, have the attention for that. So we thought that it'd be helpful to do these shorter topics, get people to know generally what's happening so you can reach out to them if you have more questions. So in the first half of the talk, we're going to be starting with Madelyn Esposito-Smith, who we're very excited was able to join us today. She's from the UW Health Behavioral Health and Recovery Clinic, and she's going to be talking on sex therapy and understanding its utility in improving patient outcomes, which those of us who work in this field know that is absolutely true. Jon's going to take over, Jon Pennycuff, who most of you know, who's in our department in our urogynecology division, talking about choosing the right vaginal moisturizer and lubricants for patients. Mary Landry is going to take over from there. She is a clinical professor here in our department and is the women's health manager at UHS, and is going to be talking specifically about Dane MAC, I think that's maybe Dane MAC, the mobile forensic nurse exams and University Heal. And again, these talks have research and clinical aspects kind of woven into them. And then the next part, next slide, is going to be talking about cancer and sexual health. Joanne Rash, who is a PA in GYN oncology and helps run the WISH clinic, will be starting with the clinical need and outcome measures related to cancer and sexual health. Janelle Sobecki, who is a GYN oncologist in our division and also works in the WISH clinic, will be talking about collaborative and academic partnerships. And then I will end the talk with talking about setting standards in this field and generating evidence. And then ideally, we will have some time for discussion. We'll see by the time we get through 6 people. Our goal is to still have time for questions and discussion. I know that Madelyn Esposito-Smith does need to leave after her talk. And so hopefully we'll be open for people emailing with questions, but won't be available for the question and answer session. And with all that, she can take over with her talk. Oh, just before she does, we do have a disclosure slide I should probably share. We can move on to that. I'll let you read it. And we can move on.
Hi, everybody. Just letting you know this morning that David Kushner, Mary Landry, Janelle Sobecki, Madelyn Esposito-Smith, and Joanne Rash have no relevant financial relationships with ineligible companies to disclose. The speakers do not intend to discuss any unlabeled, unapproved uses of drugs, devices in the presentation. Jon Pennycuff has one relevant financial relationship with ineligible companies to disclose, Renovia Inc., but he does not intend to discuss any unlabeled, unapproved uses of drugs, devices in his presentation.
Thanks for that, Jamie.
Yep.
All right, the stage is yours.
Thank you so much for having me. I'm thrilled to be here. So I'm going to be discussing a little bit about sex therapy and what sex therapy can offer your patients, as well as what exactly is sex therapy and the presenting issues that we can address with this modality. Next slide. So as a result of this, we'll be able to define what sex therapy actually is, and as well as discover presenting issues that can actually be addressed within sex therapy. So what exactly is sex therapy? It's a specialized form of psychotherapy. It does not involve sexual touch, examination, anything of that nature. It is talk therapy, and it addresses sexual dysfunction with sex education, psychoeducation, behavioral health interventions. I collaborate with multiple departments because I'm not a medical doctor. I'm a licensed professional counselor, and so I involve other departments in my work. Gynecology is a primary referral source, and so I will collaborate routinely with you, especially if I have medical questions as well. With sex therapy, it also can include couples therapy. I do provide that. And sometimes to bring in partners, I may encourage them to come in as guest stars to lessen the pressure of being included. And this can be really beneficial to improve communication. One thing I've really come to appreciate with sexual health and mental health for that matter is that many couples, the most communicative and healthy and supportive couples, this is usually where they struggle, is discussing sexual health. It's so stigmatized and sensitive. And so having a mediator there, as well as someone to normalize their experience and provide recommendations that are going to be effective moving forward can be really helpful. And then sex therapists, we can be counselors, we can be social workers, marriage and family therapists, psychologists. I did want to note, of course, that Medicare only covers psychotherapy covered by social workers and psychologists, and this is a big barrier in the field. Okay, so what exactly happens in a sex therapy session? So initial session, I'm reviewing their mental health history. I'm looking for anything underlying that might complicate our work together. Things like psychosis is going to be a really big one. Acute, severe PTSD can get in the way of sex therapy, understandably so. Severe, persistent mental illness, depression, bipolar disorder. So I'm really ruling out anything, as well as substance abuse and addiction. I'm really ruling out any kind of contraindications that would limit our movement in sex therapy. I'm laying out as well their goals for sex therapy. What do they want to accomplish? With sexual health in the world of sex therapy, normal is whatever the client describes to be in front of me. If it's uncomfortable, then that's kind of where we can discuss it. But there is no normal function. It's what the client describes to be in front of me. The only times I have concerns, of course, is consent. That would be an area of concern. But when I'm working with somebody, healthy is how they define it. During the first initial session, I'm identifying goals using the client's language, as well as making recommendations, including looping in other care team members. I'm also figuring out who else are they seeing so I can make sure I can follow up with that person if I have any questions or concerns or want clarification. Follow-up sessions, I'm pursuing and addressing their therapy goals. I'm using evidence-based approaches like cognitive behavioral therapy, solution-focused therapy. I'm trained in eye movement, desensitization, reprocessing, and I might use that as well. It always includes sex education and normalization. Session length, 45 to 50 minutes. And depending on systemic barriers, frequency and duration can vary. With my work at UW Health, availability can be quite limited. And so if I'm working with somebody who wants something more often, then I would refer out to the community. Cool, so presenting issues, I work with all of these and more. I'm always surprised by what I hear in session. So low sexual desire or arousal, desire discrepancy, which is like playing 4D chess with my couples that I work with, where desire can be easily dampened by the most minor of things. Heat right now, as I'm hearing a lot of, right? Like anything can dampen desire. And so when I'm working with couples, and individuals. I'm trying to figure out exactly what's helping desire and what's inhibiting it. And with gynecology, you're probably seeing this a lot, especially with treatment options, and treatment specifically can be very unsexy. And so I work on desire and how to sexify your recommendations. Concerns, of course, related to paraphilias, fetishes, questions of sexual gender orientation. Work with a lot of polyamorous and ethical non-monogamous couples. Everyone's dating each other, it seems, nowadays. I work with out of control sexual behavior. Erectile issues I often do see in this setting when I'm working with gynecology, specifically partners with penises that they do not want to cause pain for their partner who's going through treatment. And so having them come in with their partner or even individually can be really useful. Painful penetrative sex, jumping down. That's something that I do see in practice quite a bit. And if they are not linked up with pelvic floor gynecology, then they are immediately referred. Anything with pain, immediately I refer them. I want them to be looked at. A lot of my work when it comes to painful sex is addressing any exacerbating conditions. Could be trauma, it could be religious beliefs, it could be poor sex education. And I work on the psychological components that we can move a little bit. And of course, sexual trauma, although depending on complexity, I may refer that person to see somebody in tandem or primarily to work on the trauma. Of course, intimacy issues and anorgasmia also come up in practice. So collaboration methods, it's really great with UW Health. You can you can CC me in a message. You can send me an RE patient. You can ask me for my phone number, I'll call you. There's a lot of benefits in collaborating. I don't like to work in a silo because I tend to miss things pretty quickly as a non-medical provider. I want to make sure that I'm being very realistic with my clients of what is possible with sex therapy. So collaboration really helps me to improve consistency in my recommendation. So I'm not recommending something that you disagree with and vice versa. I can clarify clinical impressions. Are we seeing the same client? How are they coming to you? How are they coming to me? Are we being consistent with what we're seeing? I can also collaborate to help understand specifically for myself how I can tailor sex therapy for that specific individual. I'm not a manualized kind of person, so I want to figure out how to best utilize this intervention with folks that best fits their needs. And I also want to provide support to physicians when you're working with a client that's that has a difficult presentation or complex mental health issues. It can drain you quite quickly. And so I'm also available to provide support and information on how to best manage a mutual client. So when and how to refer, when in doubt, reach out. I'm always available to review a chart, let you know what my impressions would be if sex therapy would be appropriate. Again, it's most effective when underlying mental health conditions are stable. If sexual trauma is the primary diagnosis, that may be something that I recommend referring out into the community or somebody here at UW that has better availability. And then at the bottom, of course, I included how to currently refer people to me. So you can refer via workstation order, or the patient themselves can call the behavioral health access line. If you have questions or issues with linkage, also feel free to reach out to me and I can intervene. And with either method, be sure to just request sex therapy or me specifically. There's a couple other sex therapists that I work with. So let me know if you are also agreeable to your client to see somebody else. Okay. I think that, and here's my contact information. So I have a few minutes. I want to open up if any questions. It looks like there is a question in the chat.
Yeah, I think just based on time and because you need to leave, I think that it would be good for you to take a couple minutes to answer questions.
I would love to.
2 or 3, but and then we'll just move on from there. So thanks.
Yes, thank you so much. Okay, I wonder.
Can you see the chat well enough?
I can, yes. Yes, do I address gender inequity, homophobia, other structural issues? Oh my goodness. Yes. So I'm constantly thinking about systemic issues. Right now, I'm hearing a lot about Roe v. Wade. So I work with a lot of clients on how to process what's going on, how to find control in an environment right now that is absolutely out of our control. It does feel that way. Everything is connected to sexual health. So, internalized homophobia, structural like racism, oppression, all of these things are connected to sex. And so helping clients to process those things with the thought that like that will help shift desire, if that's their preferred outcome. All of it is connected. People come in to discuss, racism at work. That is connected. All of it is. I hope that answered your question. So the wait time right now to get in, my first intake is at the end of July. I have a wait list right now. So it's not terribly long. And then if a client, is eager to start, I also can provide them with like books if they have interest in reading something, or I can also recommend other resources in the meantime before they work with me. There's quite a delay in getting in with mental health right now, unfortunately.
Is there maybe time for one more question if anybody else?
Of course, yes.
All right, well, I appreciate you being here and thank you. I know that you had multiple commitments, so thanks for fitting this in, and we love having you as a resource.
My pleasure. I really appreciate being included. Thank you so much. And then reach out if you have any questions in the interim too. I'm around. UW can't get rid of me, so.
All I know is when I asked anybody who would be great to talk in this spot, it came at me from like 12 directions that you were the one. So thank you.
Well, I work with fantastic people and I'm just really appreciative to be included. Thank you so much, everyone. Have a great day.
Great.
Bye.
All right, Jon, go right ahead.
Good morning, everyone. Thank you so much for having me. I'm Jon Pennycuff. I know I've met some of you, but I'm one of the new faculty members in female pelvic medicine and reconstructive surgery. And I'm sort of gonna be discussing my lotions and potions talk, which is something that's near and dear to my heart. What I don't know is, do I have control of advancing?
No, I think Jamie is going to be doing that for you.
All right, great. Then can we advance? All right, so the objectives today are to explain the evidence for choosing the right vaginal moisturizers and lubricants for your patients. So lubricants, I think the first thing that I often talk about with patients are what's the difference between a lubricant and a moisturizer. Lubricants are used at the time of intercourse, and they can be water, silicone, mineral, or plant oil based. And then they often have things added like humectants, emollients, or preservatives, and these are added to change the viscosity, the feel, the silkiness, or the like desired effect, like warming or tingling or numbing. And these all affect pH and osmolality, which we'll talk about. And their use is recommended by the World Health Organization in certain populations, and one of those populations is postmenopausal females. All right, so vaginal moistures, on the other hand, are applied regularly every 2 to 3 days, and their goal is to mimic vaginal secretions. These are formulations that adhere to the vaginal lining, and they change the fluid content of the endothelium and also change the vaginal pH. They contain polymers that hold water and then release the water over time, but they also contain excipients, which are added ingredients that are non-active to achieve a certain viscosity, pH, buffering, or preservatives to increase shelf life, particularly among like stable shelf, commercially available vaginal moisturizers. So the WHO actually recommends an osmolality not to exceed 380. So like 380 is the desired osmolality of products. Very few products reach this. So an acceptable osmolality is 1200. And I'll give you some examples of what our patients can purchase and like what we could recommend instead. It's been shown that hyperosmotic lubricants and moisturizers can induce mild to moderate irritation. So it's not uncommon to me for for me to recommend a vaginal lubricant or moisturizer, and patients come back and say it burns, it hurts, it made sex more painful. And you really have to think like, well, what are you using exactly? And what could my recommendations be instead? And very hyperosmotic can actually cause severe irritation and tissue damage. There's been in vitro studies that showed that epithelial cells and cervical cells have been damaged. And we really don't understand the role of pH as well as we do osmolality. And so there are many products designed to like lower the pH, particularly in postmenopausal vaginal atrophy. So like the pH of the product is 2.3, well, that's pretty acidic, and you're adding it to pretty fragile tissue. And we don't know if that's good, bad, if that's helpful, because it's really not been studied. There's like other stuff in these things, right? Like there's an active ingredient, and then there's the other stuff or the vehicle. Parabens are used as a preservative. They're weakly estrogenic and they're endocrine disruptors. They have been detected in breast cancer, but their role in breast cancer is not clear. There's glycols, and glycols are added for silkiness. They've been shown to kill lactobacilli. They make the cells more susceptible to HSV2. And there's associated risks with BV and Candida. And then chlorhexidine, which we all know as something for washing our hands before surgery, it's added as a preservative, and it has been shown to increase the transmission of STIs. So I think it is important to understand what's actually in these products. So basically, the recommendations are, if you have urogenital atrophy, you want to use a vaginal moisturizer 2 to 3 times a week that's pH balanced with an osmolality that's 380 or below. And then if the patient has dyspareunia, you add a lubricant that also follows the same guidelines. And then these are all WHO recommendations. And if the patient has a history of a hormonally driven cancer like breast cancer, you want to stay away from parabens. And again, this is WHO recommendations. So these are commonly used products. These are things that our patients are buying. This is what you see at CVS, Walgreens, Rite Aid, KY, ID, Astroglide. These are all like common household lubricant names. You can see the osmolality far exceeds the 1200 cutoff that's clinically acceptable. And these pHs, in some instances, in all instances, are above the normal pH for the vagina. And in some instances are almost neutral, like that of lifestyles. So the next slide is to give you some recommendations, like don't use this, but do recommend this. And again, I'm not endorsing any brand over the other. It's just that not all of these brands have osmolality and pH readily available. Yes is a really nice range of products. They have vaginal moisturizer, vaginal lubricants, anal lubricants. I think they have a baby-friendly, like a conception-friendly lubricant. Osmolality is below the 380 cutoff, and it's pH balanced. Halogyne is another good product that actually has adequate clinical data behind it. A little higher than the 1200 cutoff, but and a little higher pH, but has some good clinical data from a randomized control trial. Silk Natural is another product that's within the acceptable range for both osmolality and pH. Yes, I mentioned, and then Lube. Lube is I recommend it in a lot of patients who are cancer survivors. It's dimethicone or silicone based. So osmolality doesn't play as big of a role, and it is pH balanced. Remember, osmolality and pH are more important factors for water-based lubricants. Your Lube and silicone-based lubricants, that's not as big of an issue. I think, is there one more slide? So that really concludes kind of what I have to say about moisturizers and lubricants. And I think that the call to action would be, and I think I would love to do this for the department if there's interest, is to get a handout for like what we recommend, how much these cost for patients, how to use lubricants, how to use moisturizers. And so that's kind of a project that I would like to see if there's some interest in department-wide that we could then give to patients.
Thanks so much, John. And I think also, people can think about potential research opportunities and collaborations around this topic. This is fabulous. And again, we hopefully will have time for more questions at the end.
I unfortunately have to go back to giving mock orals to the residents, but not unfortunately, I'm very happy to do it. I'm on my break. Okay. But I'm going to put my telephone number in. So if anyone has questions, they can feel free to reach out to me.
Great. And before you do leave, take a look at the chat because there's some thoughts in there for you.
Yeah, it looks like handouts would be helpful. So I think that that's something that would be an easy collaboration. I'm actually meeting with a Women's Touch this weekend to see more products that are available to our patients and trials and things. So I think that that's something that I'll be working on the department with in the future.
Great. Thanks so much, John.
Thank
Mary.
you.
Welcome.
Great, thanks, Jamie. Hi, everybody. I'm Mary Landry, and I am delighted to share a little bit of what's been going on at the UW Campus Clinic, UHS, over this past year. It's been several years in the making with a mid-pandemic serendipitous connection between a new faculty in the Department of Psychology and a nonprofit that was launching called Dane Mac. Dane Mac is a nonprofit. Next slide, Jamie. That was founded in 2019, and the clinical person, Kim Curran, who is a co-founder of Dane Mac, to provide a single space interagency connectedness, offering survivors of sexual assault and domestic violence advocacy, legal services, counseling, legal law enforcement, as well as forensic nurse exams brought to the survivor rather than the survivor going to services. So the concept of Dane Mac is not brand new around the country, but is felt to be best practice. And Kim Curran and Rachel Sattler co-founded Dane Mac to offer it in our county for our patients and for folks who would not necessarily step into medical care for a variety of reasons. Next slide. So as part of my raised awareness survey, again showed this has been perpetual as long as I've been on the UW campus, which is over 15 years now, that 1 in 4 UW undergrad students identify that they have experienced a sexual assault. So I was, again, with this new survey, wrapping my head around what can we do better? What can we do more? How do we reach folks? And my collaboration with the Meritor Forensic Nurse Program continued with our awareness. Next slide, Jamie. That no more than 10 students actually go to Meritor per year, and it's typically under 5. And we have been trying to understand what the barriers are to the students obtaining evidence collection for a potential in the future of reporting an assault. So I was fortunate enough to be the intersection between Kim Curran, who's a forensic nurse who became a nurse practitioner, did her clinicals here at UHS, and Kate Walsh, this professor coming into Madison, who was writing for a grant to expand survivor services on our campus. She reached out to me, I connected her with Kim Curran, and together they and I provided leadership at UHS with a really couldn't turn it down offer to bring forensic nurse exams and advocacy to our students at UHS. So each forensic exam that's done through our structure that already allowed students to schedule at any point during the weekdays, 8 to 5, they can schedule an unwanted sexual encounter. And that scheduling shows up on our queue as someone's coming in at 2:20 today. And then we facilitate getting the forensic nurse to come to UHS, as well as an advocate from Rape Crisis Center. And they are here and waiting for the student that we welcome and provide a warm handoff for the services. Students can decline the forensic nurse, but Dane Mack is entirely committed to being present and not being called in. So they instead are here waiting, and if the student wants a forensic nurse exam with an advocate, it's available to them without delay. It can take up to 4 hours, as many people know, depending upon the extent and of emotional and physical support that the student needs. And our UHS leadership has allowed the clinic to remain available far beyond up until 9, 10 o'clock at night after the clinic closes at 5. So just brief numbers. Again, before 2020, Meritor's forensic nurse exams served about 4 to 10 students per year. Since July of 2021, when Dane Mack launched their pilot here at UHS as the first clinical site, we've done over 40 forensic exams. We're well on track to be above 60 at the 1 year mark. So Dane Mack, because of their success, and I'm sad to say there's such a huge need, they've added in early 2022 a second site, which is Planned Parenthood. Their eventual goal is to serve all patients wherever they show up and divulge that they're a victim and want the support of services. So next slide, Jane. So I'm open to any questions. I want you all to know of this amazing resource in Madison that is trying to support and expand services in a very collaborative way, not only with the evidence collection exams, but also with legal, survivor services, counseling, and assistance with reporting and addressing system issues.
Mary, thank you so much.
You're welcome.
There's so much we can talk about there. It's hard to transition from these short talks because it just like opens up such a new world of stuff to talk about. But we're going to keep transitioning.
People aware.
Yeah, but you'll be on. I think you can. Will you be here for the Q&A at the end if we have time
Yes.
for that?
Yep.
Okay, great. All right, so we'll move on to the second half of the talk.
Great, thanks. So I'm Joanne Rash, one of the physician assistants, and I work in the WISH clinic as introduced. Why is this a need, right? Let's just start there. So there's 17 million cancer survivors in the United States. Half of those are women, and about half of those individuals will have sexual health impacted by their cancer or cancer care. Next slide. When I started as a PA in 2001, please don't do the math, at the Marshfield Clinic, doing well, women exams, in general OB-GYN, this always felt like a doorknob question, sexual health topics, right? Do the exam, ask patients how things are, anything else I can help you with, and maybe someone would get brave enough to ask me the question. When I worked in Appleton Medical Center as well in a private practice, that pattern continued. It always felt like a doorknob question for me as kind of an afterthought. I wasn't bringing it up, the patient needed to get some courage to bring it up. And it really, that continued even when I joined UW Health in 2006. I knew it was an important topic. Sometimes an exam finding would prompt me to ask questions about how things were going, but never anything that was in my review of systems, right? In 2008, I gave a lecture to the Carbone Cancer Center nursing course about intimacy and cancer. So it was important, but it never really kind of came together until a resident research project. That's right, residents, you make a difference. And I'm going to tell you a little story. So I was screening and asking patients to participate in the survey. Tasha Johnson was the resident who put together a survey about uterine cancer and do people have risk for sexual dysfunction. And I asked this woman at the very end of her exam, things were nice and normal. She had her clothes back on, like, hi, we have a great research opportunity here at the Carbone Cancer Center. Would you be willing to take a survey? It's about, you know, folks for uterine cancer, with a history of uterine cancer and sexual health? And she really reflexively said, no, absolutely not. I'm like, okay, but now I've opened the door. So I'm like, okay, well, now that we're talking about it, can you tell me if you're sexually active? No. I'm like, oh dear. Can you tell me, is this related to cancer or cancer care? And I got the look lady response. Look lady, my husband does not want to have sex with me. He is convinced that I will give him cancer, and he's not touched me since my diagnosis. Oh heavens, is the answer that was going through my mind, because we missed an opportunity. I missed an opportunity. We missed an opportunity. And it was only when, as a provider, we were systematically asking people about their sexual health, I initiated the conversation, that the door opened. And that was like a slap in the face encounter that said, we need to do better. So next slide. So that really prompted us to, and by us, I mean, Lori Seaborn and I shared an office. We talked about this. We had this idea. We presented to Dr. Kushner, who was the division director at the time. We got cancer center leadership, OB-GYN department leadership around saying, could we develop a program? We partnered with Dr. Lindau at the University of Chicago. They were having a program, and it took us to find resources, right? We had to find resources, IT, PR, pelvic floor PT, scheduling, sex therapy. We had to kind of develop this program, and it all took us about 18 months to do so. There's a research component to the program. We had to get the IRB through. That was a very eye-opening experience for me. And so in November of 2013 is when we started the clinic. We saw our first patient. And now, let's fast forward to now, we've got 4 clinical providers. So Lori Seaborn, who's now in the breast center, myself continue to see patients. We added Megan Peterson on probably 5-6 years ago, nurse practitioner who joined the clinic. And then more recently, Dr. Sobecki, after she completed her fellowship, joined as a clinical provider as well. And we continue to partner with pelvic floor PT and our psychology partners. To date, we've seen approximately 425 patients, and we continue to have good relationships with the Women's Touch as a resource for women, and also Gilda's Club. So what is this horrible green box? So this horrible green box is just a list of the lectures I've given. I don't want you to read them. It's not important, but I've talked to the Carbone Cancer Center, to providers there, to patients there. We've talked to the department. We talked to SGO, the Society for Gynecologic Oncology, the allied health meetings with the PAs and the nurse practitioners. I've talked to the full membership in a breakout session. We do sessions for providers. We do sessions for patients. Over the pandemic, University of Iowa reached out and said, hey, can you talk about this? And Megan Peterson and I did a joint lecture. Why is this important? Because as I was building this list, I was like, wow, people want to know about it. They're curious. They want to know what we did, how we do it, which brought us to the next slide. We needed to get this out to more people, not just people that knew us or tangentially knew us, but to the world, right? So what do? You write a paper. So we wrote a paper about the development, implementation, and what do people think about the WISH program. And it was published in 2021 in the Journal of Advanced Practitioners in Oncology, right? We wanted to focus on who we thought can really like start and run a program. So what did we find out from our survey? Next slide. We made a survey. Our team made a survey. Dr. Sobecki and her fellowship had a survey. We did this joint survey together, which was a great project. And we looked at 5 sexual health function concerns. So at the top table on the left, you can see that vaginal dryness, pain with penetration, libido had concerns at initial presentation in the 80%, communication and orgasm. And so that would tell somebody, if you're starting a program, what do you need to be prepared to talk about? Then we did our interventions and we asked people, did you have improvement in these areas? And you can read the percentages there because I'm running low on time. And then we stepped back and asked some really big questions, which I like the pie graphs a lot. Who doesn't like the good pie graph? So the left-hand side says, was the WISH program helpful to you, right? So when you look at extremely helpful and very helpful, we're at 63%. And when you add in somewhat helpful, we get to 85%, 87%. And so great, the program is helpful. That's good for us to feel and know. The middle one is really like, if you hadn't come, do you think it would be worse? Your sexual function would be worse. And 71% of people thought it would be worse. And then in general, would you recommend the WISH program to other cancer survivors, and 95% of people said that. So that was great feedback that we published as well as part of our survey. Next slide. So what are we working on next? So this has not been published. We're working on getting this data published. We broke down the survey and we really wanted to hone in on things more. We broke down the data by menopause. We broke down the data by cancer type. Here is the list of the 5 common concerns. And you can see a little bit of the results, what were common and such. And so we're running late on time, so I'm just going to keep moving. That's one table that's hopefully going to be published. The next table on the next slide is really about what did we recommend, right? Pelvic floor PT, sex therapy, vaginal dilator use, moisturizers and lubricants, and was it helpful, and where are the patterns to identify? So that's what's coming out of the WISH program next. So now I'm going to pass it to Dr. Sobecki.
Hi guys, it is great to be here. I am going to be discussing some of our sexual health and cancer collaborative academic partnerships with some of our partners across the country. Next slide. Perfect. So the first thing I want to talk about is the Scientific Network on Female Sexual Health and Cancer. And this is a national network of researchers, clinicians, healthcare professionals that are focused on an evidence-generating prevention and treatment of sexual problems in women with cancer. So this network fosters advancement in science, which supports the treatment of sexual problems in women and girls with cancer, and serves as a foundation for multi-institutional collaborations. The University of Wisconsin-Madison, prior to my arrival here, actually a few years prior, played an incredibly key role in the development of this network. Dr. Kushner was one of the founding members and also served as the second national chair of the network from 2015 to 2016. The founding retreat for the network was actually hosted here in Madison, Wisconsin, and that led to application for nonprofit status for the organization actually being filed in the state of Wisconsin. And a lot of the administration side of the network was supported by our department, the UW Department of OB-GYN, for about 3 years during this time, which really helped to foster a foundation for sustainable growth for the network. Fast forward to today, and many members of our WISH program continue to be really actively involved in the network through, committees, attendance, and presentation at annual meetings, and by serving as committee members. And the collaboration with the network has led to some strong academic partnerships, which will be discussed a little bit more throughout the end of the presentation. Next slide. So Joanne mentioned our relationship with the University of Chicago PRISM Clinic, which is led by Dr. Stacy Lindau, and this has led to numerous academic collaborations between WISH and PRISM. To highlight a couple, Dr. Spencer Berla, Kushner, and Lindau collaborated on a feasibility project investigating incorporating sexual side effects counseling into routine informed consent process for women undergoing surgery for gynecologic malignancy. Dr. Lees, who many of you know is a former Gyn-Onc fellow, in conjunction with Joanne, Drs. Kushner and Lindau, they collaborated on a review article regarding abuse history and sexual dysfunction in women. We're going to hear a little bit more about this when Dr. Kushner gets to his part. And some other collaborations with PRISM include a national probability study of OB-GYNs and their communication practices regarding sex and talking to patients about sex. A review of the literature regarding treatments, pharmacologic treatments for female sexual dysfunction and their safety and efficacy in older postmenopausal women who are often neglected from some of these drug trials. And then also the development of a validated digital survey tool to capture patient-reported breast cancer surgical history for use in larger survey research regarding breast cancer and sexual health. So lots of collaboration, lots of awesome academic work coming out of this partnership. And all of the projects mentioned, most have been published, and certainly all have been presented at various meetings nationally, including SGO and the Scientific Network on Female Sexual Health and Cancer. Next slide. So let's switch gears and talk about a few things academically happening here at UW. So the WISH program patient registry that Joanne mentioned is an IRB approved prospective patient registry of patients who seek care in the WISH clinic. And as Joanne mentioned, this was developed closely in collaboration with the University of Chicago PRISM Clinic. And all patients who are seen in the WISH clinic are offered participation in the registry. And then if they want to participate, then informed consent is obtained. The data collected includes various clinical and demographic data, cancer history data, as well as the collection of validated sexual health instruments that are used in the WISH clinic, which include the PROMIS SexFS, the Female Sexual Distress Scale, and the SFQ. And some of our ongoing work with the patient registry includes moving these instruments to be digitized in our medical record and working on some data management sustainability. Next slide. I do want to highlight the second part of our WISH Clinic survey that Joanne had mentioned, which was a fellow research project of mine in collaboration with the Dr. Kushner and the APPs of the WISH Clinic. The second portion of the survey sought to determine the best timing of routine sexual function screening. So we know that these women have sexual function issues after cancer, but when do we talk to them? Do we talk to them at every single visit? Is there a time frame that we could be more strategic in our screening questions? And this work was presented at Winter SGO. In this survey, we asked patients their experience with sexual health counseling, including like the onset of problems, timing of conversations, who they talk to, barriers to sexual activity. And, just a couple quick highlights of this work. We found that nearly all patients felt that cancer providers should routinely discuss sexual health with their patients. Despite this, though, about 57% actually initiated these conversations themselves. And about half of patients reported that they noticed sexual problems within the first year after completing treatment. And most of the patients, 90%, came to the WISH clinic after completing treatment. And then interestingly, by cancer type, breast cancer patients were more likely to initiate conversations themselves compared to other cancer types. And then younger women under the age of 53 were more likely to first notice sexual problems and bring them up with a provider. So lots of interesting data from that work. Next slide. Another area of academic collaboration is in partnership with our radiation oncology providers. So women who undergo radiation treatment for gyn cancer experience a lot of vaginal mucosal changes that can result in pain with intercourse, vaginal agglutination, and this can interfere with sexual function as well as routine pelvic exams for surveillance. And so vaginal dilator therapy is widely recommended, but there's actually not a lot of data about it. And recently, providers have switched to using vibrating vaginal wands, which are thought to stimulate the vaginal tissue and increase vaginal blood flow to a greater degree than just, your typical static dilators. But there's really not been a lot of data generated in how patients, adhere to this therapy and how they perceive this therapy. So this study was a prospective cohort that was conducted here at UW in collaboration with our rad-onc colleagues, which looked at adherence and barriers, and patients were enrolled at the initiation of dilator therapy and kind of kept a diary of use and barriers over about a 4-month period. And just a couple of quick highlights. The top barriers that patients reported were being too tired to use the wand, not being able to use the wand in the shower, and perceiving the wand as a sex toy was a barrier for some patients. So this work has generated really excellent data for improving our counseling practices for vaginal dilator use both in gyn-onc and rad-onc clinics, and we are currently working on publication for this. And like many of the projects that we've talked about today, this project was actually led by one of our former residents, MJ Cow, and it really highlights the WISH program's successful track record of supporting trainee level academic work. I certainly have had a wonderful experience both as a trainee and now faculty, and I think WISH has had a long-standing history of really supporting and fostering our trainees. So with that, I'd like to hand it over to Dr. Kushner, and he's going to talk about the last part of our talk today.
All right, thanks, Janelle. I'll bring it home. And then hopefully we'll still have a few minutes for questions. So what I was going to finish this with today was just a little bit about some of the goals of the WISH Clinic in terms of setting evidence-based standards and also trying to get answers for our patients by generating evidence. So, next slide. What we started to see as we started collaborating nationally was that the word was getting out that this is an important topic and that there's a lack of information in this field. And so we were thrilled to be invited for a review by the June Oncology Journal. And we partnered with Jean Carter, who's at Memorial Sloan Kettering. And it was the first review of this topic that I'm aware of in June Oncology. And what we talked about here was a stepwise approach to the problem. We talked about as you have increasing complexity in terms of sexual health issues in cancer patients, there are things that you can just talk to patients about that would be helpful. There are things that need basic interventions, and then there's things where you need to refer to a specialized center, and sort of went through that here. And I think this ends up being a relatively impactful publication, which we're really excited about. Next slide. I was really honored to be asked subsequently to be on this task force. So so ASCO, which is a much larger organization, it's basically the national organization for cancer providers in the U.S. What they do is when a recommendation for cancer therapy or any such thing comes out anywhere internationally, then they decide whether they're going to adapt that, they're going to just adopt it as is, or whether they're going to review it in some way. And the Ontario Cancer Society came up with guidelines on sexual problems in people with cancer. This is in men and women. And it was a really outstanding guideline, but it did need some adaptation per ASCO. And so I was part of the panel to look at those guidelines, adapt them, and then republish them. And so this is that publication, and really goes through very extensively in men and women, just about everything you could think of in terms of cancer and sexual health concerns. Next slide. Janelle mentioned the registry, and with the WISH Clinic, we really had a couple goals. And although it really adds to the complexity of giving clinical care to have a database and to try to do it in an academic way, it's critically important, because the data that you're seeing only happens because as we're taking care of patients, we're doing it in a way where we're collecting that data and then we can publish on that data. And so we really put the work in, and I will, the people that have already spoken, I mean, Joanne put just hours of work into making sure that we had an IRB approved database. And then there's continual work from multiple people on the team trying to make sure that it's functional and that it works and that people put the data in well so that it's easy and accurate when it comes out. So I think it was really worth that. And I want to just highlight one current example from the database, because what we can then do is get together as a team on a regular basis and say, okay, what are we seeing clinically? And then can we then look into the database to figure out, is this real? So, a couple of years back, we were meeting and we said, okay, the database now has a lot, years of data in it. What should we be looking at? And it was really our APPs that said, we believe we're seeing abuse in our patient population that's higher than it should be. And this is something we'd really like to look into and see what's in our data. So we started looking into it. Next slide. First thing we did is realize that there was no real data out there for us to even compare to, and there was not much written on this. And so Taylor Stewart, who is at the time an undergraduate and is now a medical student here, graduating, and is going to be an OB-GYN, and then Brittany Lees, who's one of our fellows, just dove into this literature, and we wrote this publication. And this was also a collaboration with multiple different institutions, including Harvard and University of Chicago. And what we found in the literature, interesting, and we can go to the next slide, was this really fascinating sort of triangular cycle of problems where you can kind of go between any of these three issues of abuse, cancer, and sexual dysfunction and discuss the relationships. So for example, a patient with a history of abuse actually has an increased risk of cancer. and that they may not get screening. And there's lots of other reasons why that might be the case. So we discussed that. When you have a cancer diagnosis, there is increased abuse. So it's sort of down the line of elder abuse. And it's scary and it's horrifying, but it's very true. And abuse will predispose patients to sexual dysfunction, and we know that, although most women with sexual dysfunction don't have abuse history. So we started to look at all these different interactions and how one affects each other. And so that's what this review ended up becoming. And then we decided, okay, now that we understand the background, let's look at our own data. The next slide. So I know they can't read this, but this was published, or this was presented at a couple of different meetings, looking at our specific data and our data combined with that at the University of Chicago. Next slide. I'll just run through some of the basics. This is just a method slide that discussed that how the clinic works with our REDCap database, which is a shared database with the University of Chicago. So this is an IRB approved database that is combined between the two institutions. Next slide. And as Janelle already mentioned, here's some of what we use in the clinic. Next slide. And what we found, if you combine the two centers together, is that a quarter of patients that were coming into the two clinics, and that's if we both, patients stated in their survey, and then if we looked over the medical record, but a quarter of our patients had a history of abuse. Next slide. And we also found that the abuse actually correlated with the female sexual distress scale. Now, of course, this is a unique population, but it was remarkably correlated. Next slide. So from this particular study, we learned a few things. We learned the prevalence, which was incredibly high. We learned that although in this population of patients, the sexual distress rates were high, they're really ubiquitous among patients with an abuse history. And we really talked a lot in these presentations and in the subsequent publication about it's so important for patients caring for cancer patients, clinicians caring for cancer patients to understand this population and the abuse history as well as sexual dysfunction, be able to talk about these things because we need to have this conversation going. So awareness is key. Next slide. So I want to thank all the collaborators that have helped. There's way more than this slide shows. These are some of the key folks that have helped with some of the key publications. And we got through 6 presenters, and I appreciate your, you can go to the next slide. You're hanging with us, but we do have a couple minutes, hopefully, for questions.
Hi, this is Jessie. Thank you. This is all really awesome and important work. Dr. Kushner, you know that my resident research project is on postpartum sexual health, and the Wish Clinic and your efforts to kind of make this a systematic assessment, evaluation, and treatment plan for patients that express issues with their sexual health. My research project is looking at the prevalence of sexual dysfunction in the postpartum period, as well as people's interest in talking about it. And so my hope is that we can, if we see issues that are this widespread, kind of create a systematic approach as well. So if there's anybody out in the world who's interested in sexual health from a postpartum perspective, please let me know, because I am really passionate about kind of implementing this in our clinics and helping out patients in the obstetric world.
I mean, to me, this is one of the goals of these talks, is to get people to excited about this and find folks that maybe like, oh, I didn't realize there were other folks working on this. So thanks for bringing that up, Jessie. We would, there is a need for the same kind of clinic for non-cancer patients that doesn't exist in Madison, and it would, and for pregnant patients as well. So I appreciate that.
Yeah, I just want to echo again with the consistent sobering statistic of 1 in 4 UW students, your numbers of 1 in 4, it all is sad that more science and effort hasn't been directed, and, you know, wait times, no disrespect to our behavioral health folks who are overwhelmed, but a first intake, you know, in July and it's May. It's just, I hope that we as systems can continue to push, press, advocate, and do better to gain access with evidence informed care. And I applaud Dave and group for all that you're doing. It's outstanding and very much needed.
Appreciate that. I know we're supposed to give the 5-minute break as the chair of the wellness committee. Of course, we went over, so there you go. But we should probably wrap it up, and thanks everybody for their time today and their attention, and have a great day.